Evening, everybody, and welcome again to another great conversation with a doc. This evening, you'll be listening to Dr. Gary Vocell, who is the Director of Movement Disorders at MedStar Franklin Square Medical Center and Assistant Professor at MedStar Georgetown University Hospital. And he's going to be talking about atypical Parkinsonism. I don't think I said that right. As always, please remember at the end of this, we're going to send out an evaluation. I would really appreciate it a lot if you would fill it out and send it back. It is important. And with that, I'm going to turn it over to Dr. Vocell.
Hi, everyone. Thank you, Judy, for that introduction. Like she said, I'm Dr. Gary Volkell. I practice at MedStar Franklin Square Medical Center, and we're going to be talking a little bit about atypical Parkinsonism today. Just a little outline of the talk today. I'm going to just start off talking a little bit about Parkinson's disease and what Parkinsonism is, because that's sort of what the atypical Parkinsonisms are based off of. This is a topic that's near and dear to my heart, just because it is what sometimes makes a diagnosis a little bit more challenging. That not everything is Parkinson's disease or not Parkinson's disease. There are other diseases that kind of look like it, which can make it a little bit confusing. So it's nice to be a little bit familiar with these things, just in case it's not the obvious answer of Parkinson's disease. Just to start off with what Parkinson's disease is, we have to talk about dopamine first. So dopamine is a chemical, it's a hormone or a neurotransmitter that's created in your brain, and it moves throughout the brain and the rest of the nervous system to send signals and messages, and it helps with things like our motivation and reward, having normal movements, things like that, and normal mood, things like that. It does a lot of different things. And it's created in, hopefully you guys can see my cursor, it's highlighted in red in this picture here, an area of the brain called the substantia nigra. That's kind of like the powerhouse or the factory where most of the dopamine is made. Um, and the so that's where these brain cells make the majority of the dopamine, which then go out to um, other parts of the brain. So here we have these other areas of the brain that are kind of like this magenta fuchsia. I don't know what color you call that. This magenta color here, which are these structures within the brain called the basal ganglia. And you can still see the substantia nigra here, but the dopamine is made there. It goes out to these other basal ganglia, and these things play a role in us having things like normal movements, kind of fine-tuning our movements. And once the dopamine sends that message to where it needs to go, it then gets broken up and recycled. Dopamine's a precious resource, so we're always trying to hold on to it when we can. And that's sort of the life cycle of dopamine. Now, in Parkinson's disease, or diseases like Parkinson's disease, but specifically Parkinson's disease, we get this abnormal protein, which I'll talk more about the weird abnormal proteins a little bit later in the talk. But the abnormal protein that develops in Parkinson's disease is called alpha-synuclein. And when this protein develops in Parkinson's disease, it can accumulate all over the body, but it ends up in the substantia nigra, and it kills off those brain cells. So when that happens, those brain cells die and they disappear, and then those people start to make less dopamine. And over here, this is a cut of two different people's brains. So the one on the left here is somebody without a disease like Parkinson's. And you can actually see the substantia nigra here. So substantia nigra means like black substance. And that's in part because it actually looks dark, and you can kind of see these black bands here, and that's the substantia nigra. And the reason it's black is that the creation of dopamine, that whole pathway, is also involved in, or it's related to the melanin pathway, which is what gives skin its color. So it's very dark here. In somebody with a disease like Parkinson's disease or atypical Parkinsonism, those brain cells will die and then they can disappear. And you can still kind of see those bands here. They're just much fainter. They're kind of gray as opposed to really dark. But that's the idea, at least in Parkinson's disease, we have this abnormal protein coming in here, killing off those brain cells that make dopamine. That person has less dopamine, and then they start to have those symptoms of Parkinson's disease. So we'll talk about the symptoms of Parkinson's disease. There's two categories of symptoms. There are motor symptoms, which affect the way people move, and then there are non-motor symptoms, which affect everything else. And we'll talk a little bit about both of them. But with motor symptoms, um, sorry, there was a little bug there. There with motor symptoms, we see these kind of four main changes in the person. So I'll explain what each of these means. But in general, we get this one here called bradykinesia. Bradykinesia means slow movements. So brady means slow, kinesia is movements. So with somebody with Parkinson's disease, those motor symptoms of Parkinson's disease, they get very slow. That could mean that they're not as expressive with their face. So like they have a really good poker face. Maybe they don't blink as much. It could mean that their voice gets softer. It could mean that when they are doing fine motor tasks, they're just slower with doing things like that. There's rigidity, which is stiffness, or usually in things like arms, legs, it can be in the back. It can be a little bit painful as well. So people get slower, they get stiffer. Um, they can develop tremor, which is what I think most people think of with Parkinson's disease. It affects about, or I should say, 70% of the people with Parkinson's disease can develop a tremor, usually in an arm, a leg. It can be the mouth or the jaw, the head, and the neck. And then they can get postural or gait instability. So changes in the way they walk and keep balance. Maybe they're more likely to fall. Maybe they'll have freezing of gait where their foot gets stuck to the ground, things like that. And why am I calling it Parkinsonism? Well, these motor symptoms, the other name for them is Parkinsonism. So what does that mean? Well, like I said before, people with Parkinson's disease get motor symptoms and non-motor symptoms. And commonly we're thinking about these motor symptoms. So these four symptoms here. And somebody with Parkinson's disease does not need to have all four of these to have Parkinson's disease. They really need to have this bradykinesia, slowness of movement, and at least one of these other three things. So that's enough to usually help make the diagnosis. Um, and what Parkinsonism means, it means that somebody looks like they have Parkinson's disease, right? So it looks like, they've got some of those motor symptoms and it looks like they have Parkinson's disease. But Parkinsonism alone isn't a diagnosis. So we need to figure out why somebody has Parkinsonism. So sort of an example I like to give is if somebody had a fever, that's not necessarily a diagnosis. It doesn't tell you what's causing the fever, right? The diagnosis is what's causing the fever. Is it an infection? Is it they were out in the heat for too long? Is it they had a medicine that caused it? Something like that, right? We want to find out what's causing the fever. It's the same thing with Parkinsonism. Just because somebody looks like they have Parkinson's disease doesn't mean they actually have it. So when we say Parkinsonism, we're saying, hey, this person has some of the motor symptoms of Parkinson's disease, and I wonder if they have Parkinson's disease. Um, what I will say is that Parkinson's disease is the main reason why somebody develops Parkinsonism, but there are other reasons why somebody can get Parkinsonism. Sometimes it's a side effect of a medicine. Sometimes it is one of these atypical Parkinsonisms that we're going to talk about. I also mentioned that there are these non-motor symptoms. So these are the ones that affect things that are not our movements. And there's a lot, so much so that I didn't even have enough time to put them all in here, but there's a ton that can happen. So it can affect things like our mood. It can make Parkinson's disease can make people depressed. It can make them anxious. It can reduce their motivation or make them apathetic. It can make them impulsive. It can make them psychotic. They can start having hallucinations, seeing things that aren't there, hearing things that aren't there, or having delusions, which is when people have a fixed false belief, believing something that definitely isn't true. Not a subjective thing, right? Objective, right? We would joke around amongst our friends, right? Oh, you believe that? That can't be right. But no, it's all objective in this case. Neurocognitive changes. So changes in memory, for example. So people with Parkinson's disease can go on to have their own type of dementia called Parkinson's disease dementia. It's different from Alzheimer's disease and it's different from other kinds of dementia. They can have changes in their autonomic nervous system. We'll talk a little bit more about that, but the nervous system is divided into all these different parts. And the autonomic nervous system is the part of our nervous system that does all the stuff we don't have to think about, right? So if you eat food, you don't have to tell your gut, hey, it's time to digest the food, right? It just does it on its own. You don't have to tell your lungs to breathe. You don't have to tell your heart to beat. You don't have to tell your blood pressure to adjust itself when you change positions. Our autonomic nervous system does that for us. But in Parkinson's disease, that autonomic nervous system doesn't work as well, and then it can cause problems like constipation, urinary incontinence, sexual dysfunction like erectile dysfunction, drooling because the automatic swallowing that we do can go away. There's this thing called orthostatic hypotension, which is when people's blood pressure drops when they go from a sitting down position to a standing up position. Normally, we have these sophisticated mechanisms in our blood vessels that adjust our blood pressure so that when we change positions, our blood pressure stays pretty much the same. But that doesn't always work in Parkinson's disease. And then these people, their blood pressure drops, they get very lightheaded, they may even faint and fall down and hurt themselves. They can get other altered senses, so anosmia, which is the loss in the sense of smell, dysgeusia, which is a change in how we taste things, maybe a loss of our ability to taste. Paresthesias are like numbness and tingling, things like that. Those kind of funny feelings that wouldn't otherwise be there. And then people can also develop sleep disorders, with the main one that I want to talk about being called REM sleep behavior disorder. And that's when people have these action-packed dreams. They're really vivid, usually violent. There's a lot of punching, maybe shooting, running, chasing. Um, and while they're dreaming, for whatever reason, with this condition, the brain does not paralyze the body, so people start acting out their dreams in their sleep. Not like sleepwalking, but really in their dreams. So they'll start punching, kicking in real life, and they can hurt somebody if they're sharing the bed with somebody. They can hurt themselves if they fall out of bed. But that's REM sleep behavior disorder, and we see that in Parkinson's disease. So how do we diagnose Parkinson's disease? Well, all we really need to do is talk to the person, do a really good physical exam, and usually that's all we need to make the diagnosis. Sometimes it can be a little bit more complicated. I mentioned earlier that there are other things that cause Parkinsonism, including certain drugs. So there are some medicines that make people look like they have Parkinson's disease. It causes a drug-induced Parkinsonism, even though they really don't. So if somebody comes in and they have Parkinsonism, but they're also taking a medicine that can cause that, it can be tough to know if it's just the medicine causing it or if it's from something else like a true Parkinson's disease or a disease related to it. So in those cases, we'll sometimes do a special test. There's this one called a DAT scan, a DAT scan. We only really use it to look for something like Parkinson's disease, but there's a special radioisotope called ioflupane. It gets injected into a vein. That dye, if you will, goes up to the brain and then it binds to those brain cells that make dopamine. And in somebody without something like Parkinson's disease, like this picture on the left here, you get this nice kind of symmetric pattern. It looks like these robust commas, like the punctuation mark, if you will. But in somebody with a disease like Parkinson's disease, you can see, first of all, they're not equal anymore, right? It's a little bit brighter here than it is over here. And it's certainly much smaller. And that's somebody with a disease like Parkinson's disease. I say like Parkinson's disease because Parkinson's disease and the atypical forms of Parkinsonism, we call them neurodegenerative forms of Parkinsonism, meaning that it's a disease that's injuring brain cells and that's causing somebody to have Parkinsonism. So a DAT scan will be abnormal, like we see on the right, in any of those neurodegenerative forms of Parkinsonism. But that's a lot of diseases, so it doesn't make the diagnosis for us, but it lets us know that it's not just maybe a medicine that the person's taking, that they do have a disease. Just doesn't tell us which one. There's another type of testing that can be done called a skin biopsy, where you numb a few sites of the body up and you take a little sample of skin, kind of like how you may have at the dermatologist. That gets sent away, and then we look for that abnormal protein that I described earlier called alpha-synuclein. And if it's present, that's suggestive of a disease like Parkinson's disease. When we're treating motor symptoms of Parkinson's disease, predominantly we're starting with something like carbidopa-levodopa, although there are other oral medicines as well. Carbidopa-levodopa, the way that works is the levodopa gets turned into dopamine when it reaches the brain, and the carbidopa is like a suit of armor. It protects the levodopa so that it gets there safely. And since Parkinson's disease is a disease where people are losing dopamine, it makes sense that we give them a medicine that turns into dopamine, right, to try to help them out with their movements. There are other medicines that do similar things. They either help carbidopa levodopa out, or they do other jobs to help the person with their movements. There are certain rescue therapies, kind of like how an EpiPen is used for somebody with a really bad allergy. There's something similar in Parkinson's disease. In fact, one where it is an injectable like an EpiPen, one which is an inhaled medicine. There are newer and older infusions where somebody may get a surgically placed tube that infuses a medicine into them, or a subcutaneously placed tube, like a little needle that goes right in the skin, hooked up to a pump that gives them medicine throughout the day. And then there's some neurosurgical options as well, which are things like deep brain stimulation and even certain types of focused ultrasound. And that's typically how we manage the motor symptoms in Parkinson's disease. And again, this is not really a talk about Parkinson's disease, but I wanted to do a refresher, kind of some of the bullet points, the highlights of Parkinson's disease, because we really need to understand at least those basics before we talk about the atypical forms of Parkinsonism. So this is, I'm sure, a famous picture that everyone's seen. I think I probably first saw it in kindergarten, maybe. Um, but it's the classic, is this a young woman with her head turned away or an older woman looking towards us, right? So it's an optical illusion, and it can be either one. And this is what I usually think of when somebody has Parkinsonism and when they may have an atypical Parkinsonism. It looks like Parkinson's disease, but it's actually something else, right? So it can be tricky. And I want to do a little interlude to talk about those bad proteins. I was talking a little bit about alpha-synuclein, but I also want to talk about this other one called tau. And when we talk about these diseases, all of these diseases, including Parkinson's disease, we sort of classify them by which is the bad protein that's causing the injury to the brain. And in kind of this yellow box over here, we have the diseases that are caused by alpha-synuclein. So people with alpha-synuclein can go on to develop Parkinson's disease, but they could develop another disease too. They could develop something called dementia with Lewy bodies, or something like multiple system atrophy. You can see these are all abbreviated. It'll get tiresome if I keep saying multiple system atrophy, so I may call it MSA, so I apologize for abbreviating. I'll do my best not to. There's some other diseases as well, which are kind of outside of the scope of this, but these ones in green are the ones that we're going to be talking about we just talked about Parkinson's disease, but we'll talk about these other two alpha-synuclein diseases. And then tau is another abnormal protein, and that can lead to a disease like progressive supranuclear palsy, or PSP, and corticobasal degeneration, or CBD for short. It's also been associated with frontotemporal dementia, but that's not really a form of Parkinsonism, so I'm not going to talk about that today. Well, what are risk factors for developing a disease with alpha-synuclein? Well, men are more likely than women to get it. And then there's certain genetics that can lead to it as well. Which one, and then I put this in here as well, which is that there are certain symptoms that people develop which put them at a higher risk of having an alpha-synucleinopathy, an alpha-synuclein disease. So somebody with that REM sleep behavior disorder that I was describing before, acting out your dreams in your sleep, punching, kicking, screaming, falling out of bed, those people are more likely to go on to have a disease with alpha-synuclein. So when we think about these three diseases, I often think that if somebody has REM sleep behavior disorder, they are more likely to have one of these diseases and unlikely to have one of these tau diseases. So these are things that we use to help us make those distinctions, how we can tell if somebody's more likely to have one disease or another. Other things too are that orthostatic hypotension I was mentioning before, where the blood pressure drops and people start to get lightheaded and faint, are more likely to be involved in one of these alpha-synuclein diseases. Genitourinary dysfunction like erectile dysfunction, constipation, those kinds of things make me think more that it's going to be an alpha-synuclein disease as opposed to a tau disease. Let's talk about dementia with Lewy bodies first. And as a neurologist, well, we'll get into this in a second. First, let's just describe what a Lewy body is. So, and I guess, what I should say is, as a neurologist, I'm a pedant, right? So, some doctors are pedants about things, neurologists are pedants about everything. What I mean is we're real sticklers about the terminology we use. So I'm sure that you're hearing me say dementia with Lewy bodies, but you've probably also heard the term Lewy body dementia. So is there a difference? What's the difference? Of course, there's a difference, right? Like I said, I'm going to be a stickler about it. So what's the difference? Well, alpha-synuclein and diseases with alpha-synuclein, people can develop these Lewy bodies as well, which is, this is a microscope slide, a picture of somebody's brain, a slice of their brain underneath a microscope. And they get these abnormal Lewy bodies, which again are just these abnormal protein that builds up in the brain. So why am I stressing this? Well, Lewy bodies can develop in any of those alpha-synuclein diseases. So Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. And what it turns out is that all three of these diseases can cause dementia. Predominantly Parkinson's disease and dementia with Lewy bodies cause dementia. So any disease where people develop Lewy bodies that goes on to have dementia, if they have dementia, that's a Lewy body dementia. So somebody with Lewy body dementia could have Parkinson's disease, or they could have dementia with Lewy bodies, or they could have multiple system atrophy. But dementia with Lewy bodies is its own disease. It's its own disease that happens to be a Lewy body dementia. I know it's a little bit of, like I said, I'm being a stickler here, but we do call the disease dementia with Lewy bodies because there are several diseases where people develop Lewy bodies that can go on to have dementia. Like I said earlier, Parkinson's disease is one of those diseases. So people with Parkinson's disease can go on to have a Parkinson's disease dementia, which is a type of Lewy body dementia. Just like somebody with dementia with Lewy bodies has dementia, and that's also a type of Lewy body dementia. Okay. So how do we know the difference between dementia with Lewy bodies or Parkinson's disease? Well, the timing is really the key, and it can be very difficult to distinguish these two. With dementia with Lewy bodies, we classically think of these people as having cognitive changes. So, change in the way people are able to remember things, the way that they think about things, the way they take care of themselves, the way that they behave. Those things change, and these people can develop psychosis. So they can have visual hallucinations. So seeing things that aren't there, hearing things that aren't there, stuff like that. Um, and all these things, like I said before, they happen in Parkinson's disease. So how can you tell the difference between Parkinson's disease and dementia with Lewy bodies? Well, in Parkinson's disease, these kinds of cognitive changes and hallucinations, they usually don't happen very early in the disease. They tend to happen years into the disease, like 5 years, 10 years into the disease. That's when we start to see those symptoms develop. But in dementia with Lewy bodies, it tends to happen very early in the disease, like within the first year of the disease presenting. And when I say the disease presenting, I mean those people start to have motor symptoms, right? Bradykinesia, slow movements, rigidity, stiffness, right? Tremor, gait and postural changes. And within the year of getting those motor symptoms, that Parkinsonism, they also start to have visual hallucinations. They also start to have cognitive decline and dementia. So having that happen earlier, that is much more suggestive of dementia with Lewy bodies. But a lot of times it can be difficult to know the exact timeline, right? We don't, these can be gradual changes. So not everyone's always aware of, well, did the visual hallucinations start in 2020? Did they start in 2023? Right? It can be really tough to know. And for that reason, a lot of times a neurologist will probably say something like, well, I think you either have Parkinson's disease or dementia with Lewy bodies, but I'm not 100% sure which one. And I usually call these diseases sister diseases because they are so similar. And for the most part, we treat them pretty much the same. In general, people with dementia with Lewy bodies tend to have a harder time, and their course usually progresses a little bit faster, and they tend to have more problems earlier on because of those cognitive changes and the psychosis, right? So Parkinson's disease, if you had to have one, and hopefully you never have to have either, Parkinson's disease is the better of the two because it tends to be a little bit less aggressive than dementia with Lewy bodies. But in general, we treat them about the same. We treat Parkinson's disease and dementia with Lewy bodies the same. And sorry if you see this notation of idiopathic, that just means in this case idiopathic typically means we don't know. But what I really mean by this is it's just saying that the Parkinson's disease is because it's Parkinson's disease. It's not caused by anything else. So it's like the main Parkinson's disease, what we're really talking about when you see that there. So like I said, sometimes it's not always essential that we know if it's Parkinson's disease or dementia with Lewy bodies because we're going to treat them basically the same. For the psychosis, like hallucinations, we'll use antipsychotic medicines, medicines like usually like quetiapine or pimavanserin, which goes by the brand name Nuplazid. We'll use these things called anticholinesterase inhibitors. Acetylcholinesterase inhibitors. I should say. My apologies. Those are things like donepezil or which goes by the brand name Aricept. Um, there are for all the things that spring up, we're going to do a lot of symptomatic management. So if somebody's constipated, we'll offer them treatments to treat the constipation. If somebody is having blood pressure changes, we'll offer them medicines to help manage their blood pressure. If they're having walking and balancing issues, because these diseases affect the way people walk, we'll set them up with physical therapy, occupational therapy, speech therapy if they're having difficulty swallowing or if their voice is very soft. And then in dementia with Lewy bodies and the other three atypical forms of Parkinsonism, we can't offer those neurosurgical therapies like deep brain stimulation. So I'll just make a note of that here. We really only offer that of all the types of Parkinsonism, we only offer that in Parkinson's disease. So that's dementia with Lewy bodies. I want to go on to the other alpha-synuclein disease, which is multiple system atrophy. And I see somebody put in the question and answer, how about multiple system atrophy? So hopefully I'm about to answer your question now. But let me know if you still have questions at the end. So multiple system atrophy or MSA, it went by a lot of different names in the past. I've included some of them towards the top here: Scheidegger syndrome, olivopontocerebellar atrophy. These are actually describing the areas of the brain that get injured for multiple system atrophy. But like I was saying before, this is a type of alpha-synuclein disease. We see some of these changes in it. These are very technical, but in case you are interested, we also see Lewy bodies. And we start to see gliosis, which is like scarring and degeneration of different parts of the brain cells called the axons. And these are things that, at least if we were able to take the person's brain out and look at it under a microscope, would be able to let us know that, this person did have multiple system atrophy, not Parkinson's disease. Because a lot of these diseases look alike, we're often doing our best guesses and using these different things that I was telling you to look out for, that I'm looking at, not that you have to look out for, but that I'm looking out for to try to distinguish these diseases. The truth of the matter is sometimes we get it wrong. It can be very tough. And the only way to know with 100% certainty is after the person has died, to take their brain, look at it under a microscope, and what we call the pathology. And then we're able to figure out, it turns out, they had these types of changes, which we only see in multiple system atrophy. So they didn't have Parkinson's disease, they had multiple system atrophy, right? So ultimately, that's always the answer. But we use these other tricks and things that, when people are describing their symptoms or that we're seeing on their exam, that's how we try to make a guess as to what the person has. Unlike Parkinson's disease, which we usually say people die with and die with, not die from. Multiple system atrophy is lethal, as are the remainder of these atypical forms of Parkinsonism. Life expectancy after symptom onset is about 6 to 10 years. We usually break it down into two main subtypes, which is where people with multiple system atrophy look more like somebody with Parkinson's disease, so we call it the Parkinsonism type, or they look more like they have this thing called cerebellar ataxia. Ataxia is kind of like a clumsiness. So if you wanted to think about somebody with ataxia, you'd think of somebody who just drunk a lot of alcohol, maybe drunk, right? Where they may have blurry vision, they'll slur their speech because they can't move their mouth and tongue appropriately to make all the right sounds. When they reach for things, they knock them over, they stumble, right? That's ataxia, when people are kind of clumsy. And with multiple system atrophy, they can get injury to their cerebellum, which is the balance and coordination center of the brain. That's the part of the brain that gets injured from drinking too much alcohol. But yeah, and it causes people to look kind of clumsy, like as if they were drunk. So some prodromal symptoms. Prodromal means symptoms that start to occur even before the person obviously has the disease. So the main one, just like with the other alpha-synuclein diseases, Parkinson's disease and dementia with Lewy bodies, people with multiple system atrophy develop REM sleep behavior disorder. The reason I'm stressing that is one, it's an indicator that somebody likely has an alpha-synuclein disease, but the other is REM sleep behavior disorder can happen in somebody years, even decades before they go on to have one of these diseases, all the other symptoms. And certainly having REM sleep behavior disorder puts people at an increased risk of going on to develop Parkinson's disease. It's not a guarantee, but there is a risk associated with this. But this is certainly something that can happen before they start to have those motor symptoms or any of the other serious symptoms that are associated with multiple system atrophy or Parkinson's disease. Also with multiple system atrophy, they get a lot of problems with their autonomic nervous system, which we were talking about before. That lightheadedness with changing positions, inability to sweat properly, bladder dysfunction like urinary retention or loss of control of your urine, sexual dysfunction like erectile dysfunction, reduced libido, constipation. These are things that can start happening well before it would be obvious that somebody has multiple system atrophy. Other symptoms that we look out for that can help us with the diagnosis is certain exam findings like faster than normal reflexes. They can have this thing called a striatal toe, which I tried to show a picture of this person here, the left toe, big toe kind of pointing up, where people have injury to the brain and it's causing kind of changes with how we're moving different parts of the body. That's why we're seeing that. These people tend to become very unstable with walking, just like with Parkinson's disease or dementia with Lewy bodies, but it tends to happen more rapidly than somebody with Parkinson's disease, to the point where they may even end up in a wheelchair earlier than you would expect. Whereas somebody with Parkinson's disease may not need a wheelchair ever, or may not need one for many years to even a decade or more. They tend to have kind of a funny way of talking where they may stress their syllables inappropriately. They'll have difficulty swallowing, dysphagia. They have this thing called anterior collis, which is when the head, as you can see in this picture up here, of the woman, it gets kind of pulled forward. So basically a change in muscle tone is forcing the head forward. So that can happen in multiple system atrophy. They can get these cold hands and feet, which we call the purple glove sign, right? Kind of shown over here. And that has to do with our body not regulating temperature the correct way. Again, that's part of the autonomic nervous system. We talked a little bit about those severe urinary symptoms. They can get myoclonus, which is like a jerky kind of movement. They can get stridor, which is when the breathing airway is partially blocked and it causes kind of an abnormal breathing sound. And this is usually what ends up being causing the person to die, is that inability to breathe properly. It usually happens when somebody is sleeping and it's harder to keep the airways open. We talked a lot about orthostatic hypotension before, but that's when the blood pressure drops when people go from, for example, lying down or sitting down to standing up. This is a huge thing that we see in Parkinson's disease, dementia with Lewy bodies, but especially multiple system atrophy, because for whatever reason with multiple system atrophy, the autonomic nervous system seems to be heavily affected. So people tend to get these blood pressure problems. And usually the initial treatment for something like this is lifestyle modifications, drinking lots of water, especially drinking like a nice big glass of water in the morning to set them up for the day. Hopefully not drinking lots of water right before bed, because I don't want somebody having to pee all night, because then they're not going to get good sleep and that can cause them to have a bad day the next day. But really kind of front loading your day with lots of water to hydrate. Having frequent smaller meals, and that's to help prevent something that we call postprandial hypotension. So if somebody has a big meal, a lot of blood has to rush to your gut to kind of work on digesting it. So if all your blood is rushing to your gut, you might start to feel lightheaded after you've had a big meal. But smaller meals can help maybe prevent that. A high salt diet, I'm one of the few doctors who tells people to add salt to their diet because that'll boost blood pressure. Things like abdominal binders, compression stockings, usually going all the way up to the hip, to the waist, right? These are things that are going to help return blood flow back to the heart and keep the blood pressures normal. Then elevating the head of the bed so that people aren't lying perfectly flat. There's maybe an angle to it, or if they're in a recliner chair, they're not all the way flat. Maybe they have some pillows propped up under their head. If those kinds of things aren't working, that's when we talk about adding a medicine, classically something like midodrine or fludrocortisone. These are medicines that actually increase blood pressure. So as opposed to a medicine that will decrease it, this does the opposite, and it can boost people's pressures to help them from dropping too much, causing them to faint or fall. We certainly don't want these people to fall, nobody to fall, but people are at a higher risk with multiple system atrophy. These are some MRI brain images that we look for. Sometimes there can be some signs here that are more suggestive of multiple system atrophy. Classically, we talk about this thing called the hot cross bun sign. If you look kind of in the middle of the picture here, this is an area of the brain stem called the pons. And in this way, we call this an axial cut, where the brain is kind of, if you can still see me, kind of getting cut like this. And over here, you can see the pons has this like plus sign, like kind of like how a hot cross bun would. And that is suggestive of multiple system atrophy. We also see shrinking of the pons. So this is what we could say a sagittal cut. So this is like a profile of the person's head. You can see their nose over here. Their eyes would be over here, but it's in the very middle, so we can't see the eyes. You can see their lips and their chin over here. But right in the middle on the brain stem, this part over here, the pons, is really shrunken, and the cerebellum, that balance and coordination center, is really shrunken. It's really missing a lot of itself. And that's why we get those that ataxia I was describing earlier, because when the cerebellum is injured, that can happen. Well, how do we treat this? Well, excuse me. We treat this the same way that we start treating Parkinson's disease, which is with carbidopa-levodopa. One of the problems is that carbidopa-levodopa can worsen the orthostatic hypotension. It can make the blood pressures drop more. So we have to be very careful with how we're using this medicine. Sometimes we don't use it at all. Because walking can become so difficult, especially if you're getting lightheaded, and in general, people with multiple system atrophy have a harder time with walking. We often start with physical therapy and occupational therapy, but again, a lot of these people will end up needing a wheelchair not too long into their disease. We want them to see a speech therapist to help with that kind of funny sounding voice, but also to make sure that they are not swallowing things in a bad way, that the food is going down into their lungs. Hopefully they're going to see a sleep specialist to evaluate them for the stridor. That's when I was saying the breathing passages were closing, especially at night, because that can be lethal. Um, the Oftentimes we talk about palliative care. I feel like we don't talk about it enough. Palliative care is just really any care where we're not trying to cure something. In fact, probably most of what most doctors do is palliative care, right? It's what our moms do, right? If we fall, and when we're kids, we fall, we get a scrape, mom kisses it, it feels better. That's palliative care, right? Very effective, right? There's nothing wrong with palliative care. It's great. That's about most of what we do. Um, but in a disease where people can be very disabled from it and have a lot of different problems from it, having an expert on how to alleviate and reduce a lot of the struggle can be really nice. So thinking about palliative care is always nice, and that's true for really all of these diseases. I wanted to move on to those two tau diseases, which is progressive supranuclear palsy, PSP, and then corticobasal degeneration, or CBD. Risk factors are not as clear here, but we know the older people get, the higher the risk of going on to have these kinds of diseases. Um, but let's talk a little bit too. So what's interesting about tau is that we don't just see it in, you can see in the middle, corticobasal degeneration and progressive supranuclear palsy. We see it in a ton of diseases, including Alzheimer's disease, right? So we'll see it in Alzheimer's disease, as well as a few others. And you can see there's a bunch of these funny proteins, right? We can see alpha-synuclein here with dementia with Lewy bodies, Parkinson's disease, and Parkinson's disease dementia. So you can see how there's overlap. You can also see in tau it includes frontotemporal dementia, which was one of those things that I was talking about before. But when we're talking about just Parkinsonism, those atypical Parkinsonisms, we're just talking about these two. But let's talk about progressive supranuclear palsy first. It's not very common. The annual incidence, how often somebody gets it in a year, is about 2 per 100,000 people, in people in their 50s and older. And then when they're in their 80s and older, it's about 15 per 100,000 people develop something like PSP. The average age where people start to develop symptoms is about 65. Before the age of 40, very unlikely. You almost never see this in a young person. Um, and as opposed to Parkinson's disease, dementia with Lewy bodies, even multiple system atrophy, which tend to occur more often in men as opposed to women, with progressive supranuclear palsy and corticobasal degeneration, it seems to be an equal split between men and women. There are certain genetic risk factors and other things that we find that put people at a higher risk of developing progressive supranuclear palsy. These are some of the abnormal findings, again, on histopathology on the underneath the microscope, which is more lets us know it's more or less suggestive of progressive supranuclear palsy. You'll see here we're talking a little bit about these this thing called microtubule associated protein tau. The microtubules are basically the scaffolding of all of our cells, and it's what allows information. We send information to and from different areas of the cell along these microtubules. So when there are mutations that help us with creating these microtubules, that's what ultimately leads to those brain cells dying and going on to causing diseases like progressive supranuclear palsy. Sometimes tau is described under a microscope as these neurofibrillary tangles. So if you ever heard somebody when they're describing, for example, a dementia or something else, then they talk about those tangles. Well, that's tau. It causes those tangles. We see that in Alzheimer's disease as well. What happens with progressive supranuclear palsy? Well, how are you going to know that somebody has this as opposed to one of the other types of Parkinsonism? Well, for that, my apologies, my computer was doing something funny. Um, the main thing that we usually think of is that these are people who tend to have frequent, repeated falls within the first year of their motor symptoms starting. Like we said, all these diseases cause people to fall, but in Parkinson's disease, falls especially frequently, where it's happening daily, maybe. That usually starts to happen years and years and years into it. So when people describe falls very early in their symptoms, it makes me worried that they could have PSP. Um, they also have difficulty moving their eyes in the vertical direction, up and down. And that's because of the area that gets injured, the midbrain, helps control those vertical eye movements. So these are things that we classically see in progressive supranuclear palsy. You also see it sometimes called Richardson syndrome, because I was the first doctor who really described it. So the classic version of progressive supranuclear palsy is called Richardson syndrome. Over time, we've learned that there are a lot of different subtypes of progressive supranuclear palsy, just like I described two different subtypes of multiple system atrophy. It's true for these others as well. I'm not going to dwell too much on them. It gets a little bit more complicated. But unlike those alpha-synuclein diseases, people with PSP don't lose their sense of smell. They don't have that REM sleep behavior disorder. And the memory change, it's not as that severe dementia that can appear in Parkinson's disease or dementia with Lewy bodies. These are some of the names of this is sort of our diagnostic certainty, which we sometimes talk about when we're breaking it up into the different variants. So like I said, Richardson syndrome is sort of the main type of progressive supranuclear palsy, followed next probably by the Parkinsonism type. Um, and these are usually the ones that, if we're going to see this at all, these tend to be the two most common ones, but there's different subtypes which can affect people in different ways. What do we see on somebody's exam? Well, like I said, they have difficulty moving their eyes up and down. They have very frequent falls, and they usually fall backwards. They have retrocollis. So before in multiple system atrophy, I described the head getting pulled forward. Retrocollis is the opposite. It's when it gets pulled backwards. There's something called the rocket sign, which is when people, when they're getting up from a chair, they like spring up really quickly. It can be very dangerous because these people are more likely to fall. There's something called the applause sign, which we look for. We have somebody, we tell them to clap 3 times in a row like this, and we go 1, 2, 3, and we show them, and then we ask them to do it, and they just keep clapping. They can't stop. Um, they can get this, it's sometimes called the procerus sign, because the procerus is this middle muscle right in the middle of the forehead. And you can see this woman has it where you'd say maybe she has a really good poker face, right? They become not expressive with their face at all. Um, so that is something that we see very classic for progressive supranuclear palsy, even more so than in Parkinson's disease, where people also get a really good poker face. Um, and they may do things like they may overstuff their food in their mouth. They may spill things. When they're sitting down, they may like drop themselves in the chair really quickly. They may not lower themselves carefully, things like that. Um, with the falling backwards, this is how it's tested in clinic. This is me with one of my patients. I'm tugging on the back of I'm tugging on his shoulders, and I'm asking him to keep his posture. So, um, I ask him, if you feel like you're falling, take a big step back. And somebody without one of these diseases, so long as they're told ahead of time, when you gently pull back, they take a step back and they catch themselves. And do a little tug on your shoulders. Take a big step back if you need to keep your balance. Okay, very good. Stand back up. Thank you. Okay, excellent. Yeah, so you can see he was taking these very tiny steps. It was not enough to catch him. If I hadn't stood behind him, he would have fallen to the ground. So we see that in things like progressive supranuclear palsy. Other things that we see looking at abnormal images, again, this is kind of that profile picture, that sagittal cut we were describing before, where you can see the nose and the mouth. This is the brain here. This is the brain stem. Before we were describing this bulbous part of the pons shrinking in multiple system atrophy. It's normal in PSP. Instead, this top part, the midbrain, gets shrunken down, and then we sometimes call this the hummingbird sign, where it looks a little bit like the bird's beak, the head, the breast of the bird, and the tail feathers here. We don't always see this, so it's not something that we see all the time, but sometimes we could. There's also something called the morning glory sign or the Mickey Mouse sign, where maybe the midbrain in this axial cut, another way to look at the brain, looks a little bit more like a morning glory, like a flower, a little bit abnormal. And that's because the midbrain is the area that's getting injured and shrinking. Um, that classic PSP, the Richardson syndrome type, has the worst prognosis. And people usually, whoops, I don't know what happened there. Okay. People usually start to depend on others for all of their care within about 4 years of symptom onset, and they usually die within about 7.5 years of symptom onset. The Parkinsonism subtype is the most benign, and people are usually able to stay independent for a little bit longer, but tend not to live much longer than about 10 years. I want to finish with corticobasal degeneration, or corticobasal syndrome, as it's sometimes called. Corticobasal degeneration is the disease. Corticobasal syndrome is a group of diseases that look like corticobasal degeneration. So there are a few things that can cause corticobasal syndrome besides corticobasal degeneration. The other main one would be Alzheimer's disease. So anyway, that's all we're talking about when if you see CBS instead of CBD, that's what I'm talking about. But the disease that I'm interested in here is corticobasal degeneration. That's one of those atypical Parkinsonisms. Um, it's even less common than PSP. It's about 1 in 100,000. It is incredibly rare, if even possible, to develop this in somebody less than 45. So usually we see it starting at around age 64. That's a good average age. Um, and with this, there is again these basically protein changes in tau, which then injure different parts of the brain. Again, when we're looking under the microscope, we're able to look for these findings in the different types of brain cells and glial cells, which lets us know that after the person has died, oh, this person had corticobasal degeneration, not progressive supranuclear palsy, not Parkinson's disease, not multiple system atrophy. Um, the genetics in general, the risk genetics that are associated with progressive supranuclear palsy are similar in corticobasal degeneration. I know I was talking about corticobasal syndrome before. About half the time it's from corticobasal degeneration, with the next biggest reason being Alzheimer's disease. So what does this look like? Well, classically, somebody gets one limb that's very rigid, but can basically can't move at all, usually an arm or a leg. It can become dystonic, so there can be some twisting or pulling, and they may have these kind of quick, brief jerks. And then they may also have some difficulty with planning movements with that limb. So, for example, I'll just show you a little video. But normally, if I were to ask somebody, can you show me what it would look like to cut a piece of bread off of a loaf, right? You know, you pretend to hold a knife in one hand, you hold the loaf of bread with the other, and then you carve off the piece. But somebody with corticobasal degeneration in the affected hand, the one that's rigid and stuff, they may instead make their hand the knife, and they may chop like this, right? That's not how we chop a loaf of bread, right? We use a knife, we hold it with the other hand. So these are things that we'll find clinically. Um, there are different ways, again, that we would, different tools that we use to try to see, does the person have cortical basal degeneration? Are they more likely or less likely to have it based off of the symptoms that they have? Um, and one of the things too is that these people can get something called an alien lymph, and the limb that's affected, that's really rigid or misbehaving, it actually does stuff on its own, right? The person has no control over it. They don't even consider, like, their arm could be kind of dancing and moving around. The person doesn't even really acknowledge that it's their arm anymore. It does its own thing. It can be pretty strange to look at. It usually doesn't bother the person, but they really have no use of that limb anymore. Um, Apraxia again is that motor planning, like I was describing before, like inability to wave goodbye, pretend, pantomime cutting a piece of bread, pantomime brushing your hair. They may get something called agraphesthesia. So if you close your eyes and somebody draws a number on your hand, even with your eyes closed, you may be able to say, "Oh, he drew the number 3 or the letter A," right? Somebody with cortical basal degeneration won't be able to figure that out anymore. Also, if you put an item in their hand when their eyes are closed and they're just trying to feel it, like this person holding a key, with your eyes closed, if you felt it, you'd probably be able to figure out that it's a key, or that somebody put a pen in your hand, or a soda can in your hand. But people with cortical basal degeneration, they can't figure it out anymore. That's part of the disease. Um, with neuroimaging, we tend to see atrophy in the brain, so shrinkage of the brain. It's usually asymmetric. You can see kind of in this A picture here, you can see there's like a lot of empty space, a lot of blackness where there should be brain. So that's where the brain is shrunk. And typically with cortical basal syndrome, they tend to have similar lifespans to people with progressive supranuclear palsy, the Richardson syndrome type, where it's about 7 years after symptom onset. The most common cause of death in something like this is difficulty swallowing. So they aspirate and the food goes into the lungs and they develop a pneumonia and die. This is just a person, you'll notice his left hand is very affected. This is not my patient. This is actually one of my mentors is talking here, Dr. Adam. You can see the right hand move over here moved pretty normally. The left hand, not as good.
Okay, and asked it before. So take your right hand and show me how you would slice bread.
He's being asked
right hand
to slice bread with his right hand, and you see he doesn't really know what to do with his left hand. His right hand, he's trying to get a knife, but he's actually chopping his hand off, right? He's not really chopping bread.
Comb your hair with the left hand.
He's asking to comb his hair with his left hand, which is the problem hand, and he's sort of getting it, but it was a little bit more challenging.
Spread butter on a slice of bread.
He has to spread butter on a slice of bread with his left hand. He's really struggling to figure that out, right? He's actually trying to do it with his right hand, which is the one where there's less problem. Now, he's being asked to imitate these patterns, so he's struggling there.
Okay, what about this? The left hand.
Thumbs up was a little bit easier, but still kind of struggling. The thumb is kind of down as opposed to up.
Top right. Yeah.
You can try to do the live long and prosper, but again, struggling to do that.
Okay. What about the letter Z, as in zebra, with a left foot?
He's trying to have him draw letters with his foot. And again, that left side is very affected as opposed to the right side. So he's supposed to draw the letter Z, but he kind of smears his foot or makes maybe an L.
Okay. Can you tap the heel of the right foot up and down?
The right foot moves pretty normally when he's asked to stomp. He's trying to stomp the left foot. He's able to do it a little bit slower.
3 times.
That's that applause sign.
3 times.
Has to clap 3 times, but he keeps clapping. He goes 4 or 5 times. Keeps going.
When you do the finger snaps, look at the fingers and back to the camera.
I'm going to fast forward a little bit to his walking.
Come back.
And you can see when he walks here, that left arm doesn't really swing by his side. It's kind of locked up. The right arm swings a little bit more normally.
Keep walking, keep walking. Then come back.
But yeah, the left arm isn't really moving the way that we would normally expect the arm to move. Okay. How do we manage progressive supranuclear palsy and corticobasal degeneration? Well, we don't really have medicines that really treat this in a way that we would like. Oftentimes, we try carbidopa-levodopa, but usually people do not respond well to this. People with that classic progressive supranuclear palsy with the Richardson syndrome, as well as with the Parkinsonism type, can respond a little bit, but usually people with corticobasal degeneration don't respond at all. And the other medicines that we use to treat things like Parkinson's disease tend to cause more problems with no benefits. So we really steer clear of them. There's this thing called pseudobulbar affect, which can sometimes occur. There's nothing that's making them happy or sad. We sometimes use this medicine called, the brand name is Nudexa. It's dextromethorphan and quinidine together. Sometimes we use these antidepressants, SSRIs, things like fluoxetine or Prozac, sertraline or Zoloft, escitalopram or Lexapro, things like that. For people who are having drooling or these painful twisting muscle contractions, which we call dystonia, they can get botulinum toxin injections to help with that. But again, those neurosurgical options are not offered like deep brain stimulation. We always want people to work with physical therapy and rehab therapy in general to help with preventing falls, trying to maintain good mobility, and using adaptive devices like canes or walkers or wheelchairs if needed, getting speech and swallow to help with slurred speech or dysarthria, aphasia, having difficulty with speaking or understanding speech, and difficulty with swallowing. This is just to acknowledge the different people who helped with making this, including Dr. Adam, who you heard talking in that last video, Dr. Wyant, who also helped a little bit with this presentation. But that finishes it. I think I finished on the hour. I was told that there were some questions ahead of time, and I didn't see any more pop up in the chat, but I'm happy to answer those questions now.
Okay, let me get to them here.
Sure.
I had them, but then I lost. Okay, here we go. I'm going to do the short one first, I think. What do you think of time-released carbidopa and Crexont extended-release capsules?
Sure, yeah. So carbidopa-levodopa, like I said, is one of those medicines that we use to help sort of replace the dopamine that's missing. And at first, like in Parkinson's disease, we usually use what we call immediate release versions of the medicine, where you take the medicine and it works pretty quickly, a few minutes after you take it, hopefully, or 30 minutes maybe. But over time, as people lose more and more of those dopamine brain cells, they need bigger doses, more frequent doses, and sometimes we try to switch to an extended release version of the medicine so that it gives people more coverage with the medicine throughout the day. There is an extended release carbidopa-levodopa, and then there were some brand names that came out after. The first main one, which is still used, is called Rytary. And now, as of about a year ago, there's a newer one called Crexant. All of these medicines that I just said are carbidopa-levodopa. Rytary was supposed to have is supposed mostly just an extended release version where it's supposed to last longer. Crexant has a combination of two things. It has an immediate release component and an extended release component. So when people do the immediate release component alone of just regular carbidopa-levodopa, they say, well, it works pretty quickly, but then it wears off and I have to wait a long time before my next dose. I wish it lasted longer. And people who are just doing extended release will sometimes say, well, it lasts for a really long time, but it takes a while for it to kick in. I wish it worked right away. So Crexant is supposed to try to combine both of those things where it works right away and lasts a little bit longer. That has to do with how the molecule is made, how it's absorbed. Um, in general, I think, all of these medicines are useful and can be helpful with the right person, but, it depends on that particular person, what their doctor is seeing with them, what their other symptoms are. So yes, we love carbidopa-levodopa. It can be very effective, and it's nice that there are newer and newer versions, that there's more options for people. I hope that answered that question.
Okay, next question. This is a long one.
Mm.
My dad has atypical Parkinson's. Number one, what is your take on a feeding tube at the end of life for patients with MSA? What is the best practice and standard of care? Nobody talks about this. Dad currently has dysphagia, dysphagia, and is wheelchair bound. He has difficulty communicating, but he does, and he seems to be cognitively intact. He has 11 hours a day with a caregiver, and I do the night shift with him because he has issues with choking. I worry about what the dysphagia will lead to and what his quality of life might look like. I also want to understand why it is so difficult to get palliative care beyond OT, PT, speech therapy through Medicare. There appear to be only 2 companies in Maryland that provide it, and we were told by JSSA that they only provide hospice-type palliative care. I don't want to give up the option to see specialists or take him to the ER if we need to, although this seems to be what hospice wants. You want me to
Yeah,
go
so
back?
there's
You want me to go back and do 1, 2, 3?
Yeah, so there are a lot of questions in there. I think I got the gist of it. And what I will say is, since I'm not taking care of your father, um, it's tough for me to say what's right, what's wrong, what's available, what's not, just because I'm not involved in your care. And I don't want to make any assumptions and be wrong, or give misleading advice. What I will say is multiple system atrophy, like it sounds like you're describing, it does really significantly impact somebody's quality of life. And all the things, what you're describing in your father are a lot of the things that we talked about, the dysphagia, difficulty swallowing. You're asking, is it appropriate to get a feeding tube? For some people, that is the right choice, but I wouldn't be able to tell you and your father's case, your family's case, what is or is not the right answer. That's a conversation that, when I'm talking about it with my patients and going over goals of care, what somebody would want, what somebody would not want, what's acceptable, what's not acceptable. Some people, when they have dysphagia, we say, well, it's risky to just eat food like regular. You could aspirate and die. But sometimes somebody says, you know what, I'm okay with that risk. I want to eat my cheeseburger or whatever it is. I love cheeseburgers, which is why I'm saying that. Um, and we say, well, so long as you understand the risks, I would hate to put in a feeding tube if what you wanted more than anything was to eat the cheeseburger. I say, go eat the cheeseburger, right? But it's going to be different for each person. And it's very personal. And it does require sitting down and talking to people. Now, I don't know if I can go a little bit off the cuff. I'm sorry to hear that you've been having problems with finding people to help support you in all of this. There is Judy, just shut me up if I'm saying things I'm not allowed to say, but there is a really nice service called Care Patrol in Baltimore. It's all over the country, actually. Care Patrol is one word, like CARE, and then patrol, PATROL, but it's written as one word. I don't have the phone number on me right now. I apologize, just because I'm not at work. But
If the person would like, I mean, I do have their number at the office.
great.
So if
That's wonderful.
somebody,
Yeah.
if you want to call me, I can give it to you.
That's great. Yeah, I have it in my office. I'm just I'm speaking to you from home right now, but yeah, that's a great service where they help with all sorts of things. Whether it's AIDS, whether it's it's gonna make it sound like going to a nursing home. Not necessarily going to a nursing home, but any kind of like living arrangement where you can have assistance that's easier, even if that means going into an apartment, maybe not your home, but an apartment where people are able to maintain independence and they don't cost anything. They help you, make sure they're finding something that's financially feasible. They're really wonderful. So that's a good resource, and I do apologize that I'm not able. You have very good questions. I just can't answer them well without really having known your father's care and sitting down with you. So I am sorry that the system seems to be a struggle, and I do wish you guys the best. But a lot of this would be a conversation to have with hopefully your movement disorders provider.
So those are the two questions. Oh no, here's a third. Wait a minute. What is? Oh,
The care Asking about the care patrol number. I'll see if I can find it really quick on my
okay.
telephone.
Okay.
Let's see. Care Patrol Baltimore. I know it's a 410 number. I'll recognize it if I see. Oh, I found it. I'll type my answer in here. It won't be private, but it is area code 410 844 0800. I'm putting that in. Hopefully everyone can see that in the chat. Okay. Any other questions for me right now?
Doesn't look like it.
Okay.
Okay, I hope everybody's enjoyed it. Please fill out the evaluation when you get it. And have a good evening and a good rest of the summer, even though there's not much left. And thank you. Thank you, Gary.
You're very welcome. Thank you, everyone. Thanks for having me.
Night.
Take care.